Good evening, everyone. Welcome to the White Army Comprehensive Clinical class. The White Army is privileged to have Dr. Pooja Prabhu ma'am, Assistant Professor from the Department of Nephrology, MSRMC Medical College, Bengaluru, as a mentor today. We also have Dr. Nitin Nayak, Consultant Pediatric Nephrologist from NU Hospitals, Bengaluru, as a mentor today. Welcome to you, sir and ma'am.
Thank you, ma'am.
I'm Pallavi, fourth year MBBS student from Mysore Medical College, presenting today's clinical case. I welcome all the attendees to the session. Ma'am, shall I start?
Yeah, proceed.
Okay. I'm presenting a case of a 1 year, 11-month-old female child, Ms. XYZ, hailing from Nansanhalli Palya, Mysore, admitted on 22nd of August 2021 and examined on 28th of August 2021. The informant is mother and she is reliable. Presented with the chief complaints of fever since 8 days, cough since 8 days, and burning nutrition since 7 days. Here is a 1 year, 11-month-old girl child who is a known case of kidney disease with complaints of fever since 8 days, which was sudden in onset, gradually progressive, associated with rigors, more during the night, not associated with any skin rash. Also complaints of cough since 8 days, insidious in onset, gradually progressive, non-productive, no diurnal or postural variation, also with complaints of cold. Also complaints of burning nutrition. There is history of increased frequency of nutrition, previously 10 times per day, now about 15 times per day. There is history of decreased urine output. There is no history of hurried breathing and chest retraction, no history of any ear discharge, no history of vomiting, diarrhea, constipation, no history of hematuria, no history of facial puffiness, pedal edema, no history of lethargy, no history of convulsions. Course in the hospital. The child was admitted on 22nd of August 2021 after repeated urine evaluation for 3 days. On analysis, it was found that the urine albumin levels were 4+ all the times. She was started on IV medications and the symptoms were relieved in 4 days. Past history. First episode in February, the mother gives history of...
Can I interrupt you here or should I tell it everything once you're done?
We can start from the beginning.
Ma'am, we'll go till the summary end, ma'am, at the end of the history. Then we'll come back to the first beginning.
Sure.
Okay. Past history. In the first episode in February, mother gives history of facial puffiness, which progressed to generalized edema over a period of 2 weeks. Also with vomiting, loose stools, and burning nutrition and decreased urine output, for which the child was admitted and treated in Chelvamba Hospital for 20 days. She was given IV medications, after which the urine output was increased. Second episode in April end, the child presented with complaints of facial puffiness, which was progressed to generalized edema, for which she was admitted in the hospital and given injection, after which urine output increased. The child was put on oral medication once daily for 6 weeks and later alternate days for 6 weeks. Family history. The child is third born out of non-consanguineous marriage. There are no similar complaints in the family. There is no history of tuberculosis in the family. Antenatal history. Ma'am, should I tell it in detail? It was an uneventful history.
No problem. So it was first trimester, second trimester was all fine.
Yes, ma'am.
Just show me the second trimester.
Yes, ma'am. Quickening was felt at 18 weeks.
Yeah, everything was normal. No polydipsia, polyuria in the mother. Anomaly scan done. Was the mother told to have any oligohydramnios or anything? Nothing like that.
No, ma'am. She told everything was normal.
Okay, fine, ma'am.
Birth history. Vaginal delivery at 36 weeks of gestation at Chelvamba Hospital, and the baby cried immediately after birth. Neonatal history. Birth weight was 2.5 kgs, breastfed within 30 minutes of delivery. There were no prelactal feeds were not given. A stool was passed within 24 hours and urine was passed within 48 hours. There is no history of admission to NICU. Developmental history: gross motor, jumps, walks upstairs and downstairs with 2 feet per step. Fine motor, draws circular strokes. Personal social, asks for toilet. Language, says small sentences. Vision and hearing are normal according to the mother. Inference, developmental milestones are age appropriate. Diet history, exclusively breastfed till 6 months of age and continued till 18 months of age. Complementary feeding was started at 6 months. This is the diet chart according to 24-hour recall method now. And finally, the inference was there is deficit of 37% of kilocalories and protein was normal. There was no deficit.
What was the weight of the child?
Ma'am, weight is 7.5. Ma'am, I have written anthropometer.
Okay, so underweight, no?
Not very much, ma'am. It is normal only within -1 to normal. It was standard deviation.
Okay, in your examination, you will tell me that, right?
Yes, ma'am. Yes, ma'am.
Okay, okay.
Immunization history up to date according to National Immunization Schedule. Optional vaccines were not taken. Socioeconomic history. They live in a Pakka house. Overcrowding is present. Belongs to lower middle class according to modified Kuppuswamy scale. KAP is satisfactory. Summary after the history. 1 year, 11-month-old female child of birth order 3, belonging to lower middle class, who is a known case of kidney disease on treatment with significant past history of 2 episodes of facial puffiness progressing to generalized edema and 1 episode of previous urinary tract infection, presenting with complaints of fever and cough 8 days back and burning menstruation 7 days back, all relieved with medications after 4 days, with urine albumin 4+, and no significant family history, birth history, and all developmental milestones appropriate for age, immunized up to date with dietary deficit of 37% calories. I would like to think of recurrent edema, most probably of renal etiology, most probably steroid-dependent nephrotic syndrome, admitted for fever under evaluation, probably upper respiratory tract infection and urinary tract infection.
Okay, fine. So, Pallavi, you've noted it down well and your presentation was good.
Thank you.
So now I would like to state a few things.
Okay.
Can I see you? Why is your video off?
Because of screen sharing.
Okay. Okay. Okay, fine. No problem. See, my personal. Can everyone please mute other than me and Pallavi? Yes. So Pallavi, is it audible?
Yes, ma'am.
Yeah. So definitely this is a classical case of nephrotic syndrome.
Yes, ma'am.
Okay. So what I would like to suggest you is that since this child is a case of nephrotic syndrome,
yes,
the history of presenting illness should be from February. Okay. Otherwise, presentation starting from fever and cough, and then the mother was told 4+, and then putting February and April as past history it will be a little difficult to think along that lines, because this is a case of nephrotic syndrome. Your consultant should get a feel that you are presenting a case of nephrotic syndrome, because it's a continuity.
Okay, ma'am.
Right? The past history has some relevance to the present complaint, right?
Yes, ma'am.
Yeah, and this is the 3rd relapse that the child has had.
Yes, ma'am.
Okay, so your consultant might have told you that the child has come to you all. What is the chief complaint this time? You have to elaborate on that. Yes, but then at least you should mention that this is the case of nephrotic syndrome. Something you should have mentioned so that one continuity is obtained.
Okay.
Because the past history has a very important bearing on the present problem. right?
Okay. Yes, ma'am.
Yeah. So here, February 2021 and April 2021 are not a past history for the child.
Okay, ma'am.
It is a present continuing problem. That's what I am feeling.
Okay,
So
ma'am.
it would have been better if the presentation would have started from February.
Okay, ma'am.
Okay.
Yes, ma'am.
So that is one thing. So now in February, when the child presented with nephrotic syndrome kind of picture,
Yes, ma'am.
full anasarca, decreased urine output,
Yes, ma'am.
and patient was started on IV medications. Correct?
Yes, ma'am.
Let
Yes,
me see
ma'am.
that slide.
Yes, ma'am.
Yeah. So after that, the urine output increased. So what was the child put on when whether the child was started on steroids?
It was started on diuretics according to what the mother said. So
there was no steroids at that point of time.
No, ma'am. The mother didn't tell of any medications that were given.
So you
later.
will have to ask that history.
Yes, ma'am.
The way you have asked in April 2021 episode, definitely in February they would have started, and probably she has not taken or whatever. They have defaulted in whichever way it is.
Okay.
So the history there becomes very important to see. Between February and April, there is a very short period of time, right?
Yes, ma'am.
Yeah. So the steroid intake history in February 2021 becomes very important to tell that April thing was a relapse.
Yes, ma'am.
Okay.
Okay.
Which will be a continuation of the same.
Okay, ma'am.
Okay. So as an undergraduate as well as postgraduate students for pediatrics, you all are expected to know whether the child had received steroids and what was the dose of steroids.
Okay, ma'am.
Okay, so
Yes,
that becomes very important. And that's why in April 2021, you mentioned that child was given 6 weeks of steroids and followed by alternate days, right?
Yes, ma'am.
Okay. Then what happened between 6 weeks to 6 weeks? Say 12 weeks. 12 means April, May, June.
Ma'am,
So
the child came to the hospital by end of April, ma'am. So
yes,
almost
May, June, July, if we consider.
Yes, ma'am.
So if they have given her regularly,
Yes, ma'am.
were they advised to check urine? So you need to ask that, did they do a dipstick assessment? Did the child go in for remission?
Okay, ma'am.
Got my point?
Yes, ma'am.
So because this is you have fairly understood that this is a case of nephrotic syndrome, right?
Yes, ma'am.
So you will have to ask whether the child was on remission. Did the child develop trace or negative proteinuria? Okay.
Okay, ma'am.
Yeah. So because only when that is told, you will be able to tell whether this again is a relapse or not.
Okay, ma'am.
Otherwise, whether he has responded to steroids or not, we will not know.
Okay.
Correct?
Yes, ma'am.
So that will be an important history that you need to take.
Okay.
So that's why I told you that better to start the history from February, because it's just few months and it's continuing thing that is happening to the child.
Okay, ma'am.
Okay. And also, if they have taken the medication properly and they were guided properly, they will know whether a dipstick assessment was done. Did they come for follow-up?
Yes, ma'am.
Okay. And did the urine protein become negative at all? So all that history, they will be able to tell you.
Okay, ma'am.
Because suddenly in your history of presenting illness, there is fever, cough, increased frequency, burning micturition, decreased urine output, and suddenly urine albumin 4+. You know,
Yes,
if mother has told you urine albumin 4+ now, then she must be aware in the April and February also.
okay.
So this time, did she tell that the urine albumin is 4+?
Ma'am, they had informed that urine albumin was 4+ and written on case sheet. She showed us that it was written in the case sheet.
Yeah, but you will not be able to tell the examiner that it was written on case sheet. So you will be only able to tell if the mother has told you. And if it's an educated mother,
She has studied till 5th standard, and she had seen in the case sheet that they had written 4+. So she told us repeatedly that it was 4+.
4+, correct. So that's why next time when you get a nephrotic syndrome case, you make sure that you ask the mother whether urine albumin was 3+, 4+. What was the quantity of steroids given? Was she regular with the steroids? When did they stop it? While stopping, how was whether the urine dipstick was tested? How frequently they had asked you to test the urine dipstick. Okay. So this much will be the history that you need for a nephrotic syndrome.
Okay.
Okay. So how do you define nephrotic syndrome? What do you mean by nephrotic syndrome?
Ma'am, nephrotic syndrome refers to a condition with the generalized edema or anasarca, and dyslipidemia, hypoalbuminemia, and massive proteinuria. Yeah, massive proteinuria should be your first terminology that you use. Yes, what do you mean by massive proteinuria? Massive proteinuria refers to more than 40 milligram per meter square per hour, or more than 1000 milligram per day excretion of urine proteins. Yeah, for children, you'll have to tell 40 milligram per meter square. For adults or more than 12 years of age, you can tell 3.5 grams per day. Okay. So what are the components of nephrotic syndrome? Nephrotic range proteinuria is more than 3.5 grams or more than 40 milligram per meter square. What is nephrotic syndrome as such? What are the components? Like, one is proteinuria. Dyslipidemia. Then whenever there is proteinuria, what will happen to the body albumin? Serum albumin level will be low. Then there would be generalized edema due to that, and there will be it may be associated with the dyslipidemia, hyperlipidemia. Then one more important component is the thrombotic state. Yes, ma'am. Hypercoagulable state. Yes, hypercoagulable state. Okay, so component of nephrotic syndrome are these 5. Okay. Okay. So now they have given steroids. So whenever let us think that you are in a clinic and you detected this child to have nephrotic syndrome and you wanted to start on steroids. So what will be the steroids that you would like to start? Ma'am, I would like to start with prednisolone. How much? What should be the dosage? Ma'am, initial episode we had to start with 2 milligrams per kg body weight per day. Yes. Every day we have to give for 6 weeks. Then we can start with 1.5 milligram per kg per day or alternate days for another 6 weeks. Yes. So like this, if you start the total duration, some recommend it 4 weeks plus 4 weeks. Yes, some recommend 6 weeks plus 6 weeks, but we are also following 6 weeks plus 6 weeks. Yes, okay. So once you give this daily dosage of steroids, you expect the remission to happen most of the time within 1 week. 1 week. Okay. They usually it becomes negative. The urine dipstick becomes negative or trace within 1 week. Yes, ma'am. Okay. But for some, it might take 2 weeks, but for few, it will take us 3 weeks. Yes, or sometimes 4 weeks. So when do you call this, now that you have labeled this child as frequently relapsing? What do you mean by frequently relapsing? Ma'am, frequently relapsing refers to more than 2 or more episodes of relapse in first 6 months, or more than 4 relapses in any 1 year.
Madam, you are muted, ma'am. Pooja, madam. Sorry to interrupt. I think Nitin sir has already joined. He's unmuted also. I think Nitin sir, can you hear us?
Yeah, I can.
You are unmuted, sir, already. We could see you and we could hear. Please join us, sir. Once again, I welcome Dr. Nitin sir. He's a pediatric nephrologist at NU Hospitals, Bangalore, consultant pediatric nephrologist. He's also mentor of today's session. Welcome to you, sir. On behalf of our entire White Army, we welcome you.
Yeah.
Just started with the history discussion, sir. Madam is discussing.
I've gone through the history. I've seen it, and my remarks were almost the same, along the same lines as what Dr. Pooja was saying, that the history should have begun from February 2021, because that's the only way we can bring out the history of nephrotic syndrome. Based on what chief complaints we had, there's nothing to point to nephrotic syndrome in the chief complaint or in the history of presenting complaint. So it's all brought out in the past history. It would be better if it is all in one place. We describe the disease from its onset till now.
Okay, sir.
Yeah. And yeah, so this screen which I've shared, yeah, regarding the first episode, the second episode.
Yes, sir.
So the duration of steroid.
Yes,
What?
sir.
See, first episode you mentioned that the child received some IV medications and then got discharged.
Yes, sir.
But after that, you not mentioned how they've taken the medications after going back, how long they've taken, and whether the child was off medication for some time or relapsed while still on medication.
They didn't tell any history of any medications when we asked, sir. So I didn't mention it in the episode.
So was the child on medication, or did they stop medications after discharge? That's the question.
They told they have not given any medications as such when we asked them.
For the first episode.
Yes, sir.
And
So,
subsequent?
Second episode, they had given the history of the medication. So
they received 6+6 for the second episode. That's what
yes,
you're
sir.
saying.
Yes, sir.
And this is the third.
Yes, sir. Presently presented with the fever and cough and warming exertion, sir.
How was the response to treatment for the second episode?
Second episode, as per they said, it was the child became normal. They said, but I didn't probe on the dipstick analysis as such late after the discharge, sir. But they told the child was normal, and again, since as soon as the child got fever and cough, they brought her to the hospital, and then they did for 3 days. They analyzed the urine sample, and the mother was told it was 4+, so they admitted her to the hospital, sir.
Okay, yeah. So it has been steroid has been given as per 6+6 schedule itself, but they're not monitored. That's what you're saying.
Sir.
The child was asymptomatic. No follow-up visits in between, is it?
No, sir.
Nothing. No.
No, sir.
Okay. Okay, proceed.
Yeah, so I was just asking her about frequently relapsing and infrequently relapsing nephrotic syndrome. Yeah, Pallavi, what do you mean by steroid dependent nephrotic syndrome?
Ma'am, steroid dependent nephrotic syndrome refers to 2 or more relapses during the treatment with steroids, or within 14 days after stopping the steroid treatment.
Or on tapering doses also.
Okay.
When you're trying to taper, no?
Yes,
If
ma'am.
the child has a relapse, say you gave 2 mg per kg, okay?
Okay.
And at the end of 2 mg per kg of 6 weeks, you check the urine, it had become negative, okay? And then you, you confidently change
it. 2 consecutive episodes of dependence.
Yes.
It's not 2 dependence episodes at any point of time. It is 2 consecutive episodes of dependence.
Okay.
Yes, that is one thing. And when you're trying to taper, and at that point also, the child goes back to urine albumin 4+, no? That is also called steroid dependent.
Okay.
Okay. What do you mean by steroid resistant nephrotic syndrome?
There will be no remission even with the maximum dose, that is 2 milligrams per kg body weight.
For how many days? So steroid resistant nephrotic syndrome is defined as not able to achieve complete remission despite giving steroids 2 mg per kg per day for 4 weeks in children.
Okay.
Okay. You have to give full dose and you have to give for 4 weeks completely. some books also tell it as 6 weeks because there are a few late responders. So you'll have to give up to 6 weeks to see whether the child responds or not. Despite giving the maximum dose for 6 weeks, there is no complete remission. So what do you mean by complete remission? That becomes the next question.
Complete
We need
remission.
to define both remission and relapse. Can you do both?
Yes, sir. Remission refers to trace or nil protein in the consecutive 3 days analysis of urine. And relapse refers to more than 3 plus or 4 plus or more than 40 milligrams per meter square plus hour of proteins in 3 days analysis of protein of urine. Sir.
After achieving remission.
Yes, sir.
After achieving remission, that should be in your definition.
Yes, sir.
Yeah.
That means the child has achieved remission. That means it was completely okay, and then you find a sudden spurt in proteinuria. That becomes a relapse. Okay. So now your child has come with fever, cough, decreased urine output, burning, micturition. So you know there is an infection that has occurred to this child, right?
Yes, ma'am.
So they would have treated it symptomatically and all that.
Yes, ma'am.
Dr. Nitin, you want to ask anything or shall I proceed?
Proceed.
Okay. So she told about the antenatal history. Okay. So when we come to this antenatal history, especially in a kidney case,
yes, ma'am.
Okay, what you'll have to mention is about the oligohydramnios in the whether it was told in the 2nd or 3rd trimester.
Okay.
Because whenever there is a kidney dysfunction, the amniotic fluid consists of whatever the secretion happens from the placenta as well as from the urine of the child, right?
Yes, ma'am.
The child will be passing urine there. So if the kidneys are at fault, then there is a possibility of oligohydramnios.
Yes, ma'am.
Okay. So here the child in the antenatal scan there was nothing, but the birth weight was a little low, no? 2.5 kg.
Ma'am, according to Indian standards, like above 2.5 is considered normal.
So
less than 2.5
like
will
borderline.
be. Yes, ma'am.
No, let's take it this way. It's a borderline weight, 2.5 kilograms. So we need to take it with a pinch of salt. You know, it could be a low weight. Huh?
Yes, sir.
All right.
Yes, sir.
And so at what I was just looking at your slide. So at what age do you give? I mean, in which trimester do you give folic acid in the pregnancy?
Sir, folic acid will be given from the 1st trimester itself, but iron will be given from the 2nd trimester.
Right. So you need to ask for the history of oligohydramnios. You need to see why this child was the child born premature?
Yes,
think
sir.
so.
It was born in
36
weeks.
36 weeks is prematurity. So borderline premature. Why was it premature?
Sir, she got contractions in 36 weeks itself. So
Was there puerperal sepsis?
no, sir. There was no
PIH?
history of anything. No, sir. There was no history of that.
Yeah, that needs to be brought out.
Any PROM or something like that?
Yes, ma'am.
There was?
No, ma'am. There was no history of anything else.
Okay.
So, what do you think about this case? What do you think is the diagnosis in this child from the exam history wise?
Sir, it could be a
tell me.
It could be a relapse due to the presence of infections.
See, you should have presented the history as a renal ailment starting from the age of 13 months.
Yes, sir.
Yeah.
Yes, sir.
With symptoms, oliguria, edema, whatever it is,
yes,
for which this treatment was given.
Yes.
And she had repeat episodes. You cannot call it relapses when you're presenting history. Got it?
Yes, sir.
So it's assumed that you don't know the diagnosis when you start the presentation.
Yes, sir.
All right.
Yes,
So now if a child is coming with oliguria and edema, like
yes,
what this child has had, what do you think are the differentials?
Sir, oliguria and edema, it could be one is nephrotic syndrome. The other could be it could be a nephritic syndrome if there was history of hematuria. Then the edema could be due to cardiac ailments like a heart failure. It could be due to any liver involvement also. Liver failure also can cause edema.
Yeah.
It could be renal failure also.
Renal failure.
It could be CKD. Yeah.
CKD.
Yes,
Yeah.
sir.
Acute kidney injury, chronic, CKD,
Yes, sir.
nephrotic, and nephritis.
Yes, sir.
All of
But
this.
how will nephritic present? What will be the components of nephritic syndrome?
Nephritic syndrome doesn't present as a generalized edema. It presents usually as a periorbital edema, and there would be complaints
minimal
of
pedal edema, not much. Minimal pedal edema.
yes, ma'am.
Hypertension.
There will be history of hematuria or cola colored urine.
Yeah.
Then there would be hypertension.
Hypertension. Correct.
Yes.
So hypertension in this age group, 1 year, 11 months, I don't think anybody would put a BP cuff on this child. So that history you may not get, but you might have indirect pointers to it like vomiting, irritability, and whatnot. Yeah, that aside, so you need to, like I mentioned, that there could be cardiac, hepatic, nutritional, and renal causes for edema. So you need to bring out in your history why you think this is renal.
Yes, sir.
Yeah. So what are the pointers to a renal edema?
Pointers towards renal edema is usually the edema increases during the morning. Periorbital puffiness increases during the morning.
One is the site of edema, isn't it? One is the site. Cardiac is mainly dependent edema.
And liver involvement could be due to an ascites, and renal is usually periorbital and facial puffiness, which would increase in the mornings and decrease as the day progresses.
Yeah, that should have found mention in your history.
Yes, sir.
Okay. So,
and in case of cardiac,
so what do you think? One sec. So, what do you think was the course in this child? This child had repeated, remitting, relapsing illness. So it's unlikely that this is nephritis, isn't it?
Yes,
there was no cola color urine. It responded to treatment and then it repeated. There were two repeat episodes.
Yes, sir.
So most likely seems to be a nephrotic syndrome in this child.
Yes,
what do you think about the clinical course? What is the course of this child so far from Feb to now?
Sir, there have been 3 relapses till now. So it could be a frequently relapsing nephrotic syndrome.
Yes. So your diagnosis here as most probably steroid dependent doesn't come into the picture, right?
Yes, ma'am.
Yeah. So it cannot be called steroid dependent because we have not had the relapse on steroid or on immediately stopping steroids. It's nothing like that.
Yes, ma'am.
Yeah. So you will change it to something like frequently relapsing.
Yes, ma'am.
Nephrotic syndrome.
Yes, ma'am.
What do you think about the age of onset? Can you comment on that?
Yes, sir. Usually
13 months. February was 13 months.
Most common nephrotic syndrome in children is minimal change nephrotic syndrome, but the age is 2 to 6 years onset will be there. So this is 13 months, almost near 1 month. So it could be a significant lesion.
What is congenital nephrotic syndrome?
Congenital nephrotic syndrome is the onset would be at birth or less than 1 year of age.
Less than
they
what?
can sometimes have in utero also.
Yes, ma'am.
In utero to less than 3 months of age, postnatal age.
Yes.
All right. 3 months. and 3 months to 1 year is infantile nephrotic syndrome. And beyond that, it could be your idiopathic or secondary, whichever.
Yes, sir.
Okay. So why is this important? Why is this important, you think?
Sir, we can classify the disease based on this, and minimal change nephrotic syndrome is usually from 2 to 6 years, and there would be no other features other than this, and in significant lesions it could be having poor prognosis, and there would be hypertension development.
No, see, below 1 year of age, there's a 50% chance that there's a genetic cause.
Yes, sir.
Which is why you need to categorize the illness like that. So this is a borderline onset.
Yes, sir.
It's something like 12 or 13 months of age was the first episode. So this is borderline, but when the onset is at 6 or 7 months, then it's clearly infantile nephrotic syndrome. So you need to think of genetic causes when you're thinking about it, right?
Yes,
and these children have a very high chance of developing steroid dependence or steroid resistance later on.
Yes, sir.
That's why you need the classification.
Okay.
Yeah.
So what are the indications for biopsy, Pallavi?
Ma'am, indications for biopsy would be the onset of the nephrotic syndrome less than 1 year or more than 8 years of age. Then
more than 8 years or?
Yeah, get the age right, please. Upper limit?
6 years, more than 6 years of age.
No.
No.
Okay.
You give a little fair chance to children. So some tell it as 10, some tell it as 12.
Okay.
What does Dr. Nitin feel?
Yeah, the books say 1 to 10, but even if a child has an initial episode at 10 or 11 years of age, if there are no other atypical features, which I want Pallavi to describe, I would not go and biopsy the child straight away. I'd look at steroid response.
Yes.
Yeah, so at least up to 12 years of age. Beyond 12, I definitely biopsy.
Yes.
So what are the atypical features that will suggest you that it is not classical MCNS?
There could be presence of hematuria. There could be hypertension, extrarenal features.
Yes. Some syndromic child.
Yes, ma'am.
And your SRNS.
SRN, it's steroid resistant, steroid dependent.
Yes. Okay. Fine. Now, this regarding the child has developed a urinary tract infection.
Yes, ma'am.
Is it common to develop a UTI in child? How common it is?
Ma'am, I'm like not sure of the incidence, but usually children would develop, females have more risk factor to develop more than 1 year of age.
Yes. Usually in infancy, the incidence between male and female
is equal. Because it's a hematogenous spread.
Yeah. So after that, it is the female preponderance.
Yes,
so here, if the child has developed UTI, what all questions you should have asked?
Does anyone in the family have the same complaint?
No. How do you say UTI in the first place?
Yeah.
How do you say UTI in the first place? Symptoms.
Okay, symptoms. There would be features of burning micturition or crying during micturition, increased frequency of micturition.
Okay. Then?
Decreased urine output, then dribbling would be there.
Would there be decreased urine output? I don't think so.
Unless the kidneys get affected, the urine output will not decrease like that.
Okay.
Yeah, what are the other complaints the child will have?
It's the other way. These children would have frequency, urgency, isn't it?
Yes,
so they'll frequent passage of urine. Apart from that, indirect clues that the child might have a urinary infection.
There could be other features like vomiting, diarrhea also. There could be a history of constipation, which would have caused the urinary tract infection. There could be very high-grade fever, not resolving.
High-grade fever without an obvious focus.
Yes, sir.
or the child is lethargic. In an infant, not gaining weight.
Yes, sir.
Yeah. So a newborn who is not gaining weight is enough reason to check the urine to see if there's any urinary tract infection, even if there's no fever.
Yes, sir.
Okay. Lethargy, poor feeding, vomiting,
Yes, sir.
irritability.
Yes, sir.
Yeah. So all these are indirect pointers to occult sepsis, and the most common cause is a urinary tract infection in these children. So dysuria, as such, burning micturition, is a late presentation. The child must at least be able to speak to be able to say that there's some symptom there, burning. So at least 1 or 2 years of age, at least. Before that, you can't comment on dysuria.
Yes, sir.
Hmm.
So in infancy, we usually comment on crying during micturition.
Yeah. Summarize. I think your summary page is on.
Yes, sir. A 1 year, 11-month-old female child of birth order 3, belonging to lower middle class, who's a known case of kidney disease on treatment with significant history of 2 episodes of facial puffiness progressing to generalized edema and 1 episode of previous urinary tract infection, presenting with complaints of fever and cough since 8 days, burning micturition since 7 days, relieved with medications after 4 days, with urine albumin 4+, and no significant families or birth history, all developmental milestones appropriate for age, immunized up to date, with dietary deficit of 37% calories.
Okay, what immunizations should this child have received up to now?
Sir,
sorry, I wasn't there.
Yes, sir. A birth dose of BCG, OPV, hepatitis B. Then at 6, 10, 14 weeks, we'll give pentavalent vaccine.
Yes.
And rotaviral vaccine. Then at 6 and 14 weeks, fractional IPV also can be given. Bivalent OPV is also given. Then at 9 months of age, MR is given, and with that, vitamin A prophylaxis is started.
Yes.
Then 16 to 24 weeks, there would be a booster dose of MR and
15 months. 15 months.
Yes, okay, sir.
Yeah. Then
booster dose of MR, and along with that, vitamin A prophylaxis is continued.
All right. But this child had onset of nephrotic syndrome at 13 months of age, 1 year, 1 month of age.
Yes.
So have those vaccines been given? Has MMR booster been given?
Yes, sir. They told it was given.
They generally don't, right?
Yes, sir. If the child is on steroids, they generally don't give.
Yeah. And what vaccines do you specifically need to ask in these children who have nephrotic syndrome?
Optional vaccines, sir. Like pneumococcal vaccines, pneumococcal, meningococcal, influenza, varicella.
Influenza, yes, but it's optional. Varicella is mandatory.
Yes, sir.
They should have got varicella shot.
Yes, sir.
And if the child has not received, then what do you do? If the child has not received pneumococcal vaccine, not received varicella vaccine, and the child has come with nephrotic syndrome, so then what do you do in such cases?
Not sure, sir.
Not sure. So pneumococcal vaccine can be given even when the child is in relapse. Okay. To prevent severe pneumococcal infections. Varicella cannot be given when the child is in relapse or when the child is on high dose of steroids. So once the child is on low dose alternate day steroids, they give it up generally.
Okay, sir.
Yeah. Okay. So, all right. Burning micturition. So what infection do you think this child has come with this time? There's fever, there's cough, all of 8 days duration, and then burning micturition also. Do you think the child has a UTI, or do you think the child has an upper respiratory or a lower respiratory infection? What is this?
Sir, it could be a urinary tract infection. Because
why do you think so?
Suggesting features are burning micturition, and there was also increased frequency.
Can there be burning micturition in nephrotic syndrome without UTI? He passes concentrated urine.
Yes.
There could be irritation. Yeah.
Yes, sir.
So is the cough significant, or is the burning micturition more significant? What do you think there? By the history. That's all we have.
Okay, so, for the thing to suggest it as UTI, I think burning nutrition is significant, but since the child was on steroids, it could be immunocompromised, so there could be a TB infection if there was a contact. If there is
steroid the only reason to develop infection in nephrotic syndrome?
No, ma'am. The nephrotic syndrome itself is associated with the increased incidence of urinary tract infections.
Any infections?
Why is there predisposition to infection in nephrotic syndrome? Nephrotic syndrome per se, not treatment,
Yes,
not steroids,
because
not medications.
proteins are there's massive proteinuria, so there will be loss of immunoglobulins.
And complement proteins.
Yes, sir.
Yeah, even those are lost in the urine.
Yes, sir.
Okay.
So, did the child have pain abdomen or anything?
No, ma'am.
Because that is also more common, right? Whenever there is a relapse, they'll have ascites and then
Yes.
SBP kind of picture.
Yes, ma'am.
So that also you need to ask whenever there is some. See, you have upper respiratory, you have UTI. What prevents the child from developing one SBP also?
Yes, ma'am.
Okay.
What are the causes of nephrotic syndrome? Idiopathic nephrotic syndrome, not the genetic ones.
Okay, sir.
What triggers? Yeah.
There could be any infections which triggers the nephrotic syndrome.
Yeah.
There could be any endocrinal causes.
What is it? Come again.
Endocrinal causes, sir.
Endocrine? No.
If there is any associated malignancies.
Yes. So allergies. Allergies you need to mention.
Yes, sir.
Then infections. Okay. Upper respiratory tract infections most commonly. Other infections also. And immunization. Did you mention immunization there? No. So immunization also.
Okay, sir. Live attenuated vaccines. Yeah.
And malignancies. Certain malignancies like NHL, Hodgkin's lymphoma.
Yes,
this can trigger nephrotic syndrome. All right.
Yes, sir.
Yeah.
But that's not very common, right? The malignancy related.
Yes,
but infection and vaccination related.
Infection and vaccination drugs such as NSAIDs, ampicillin, all these are pretty common.
Okay, sir.
So your history needs to bring out the secondary causes. You need to see for any of those infections, HIV, HBsAg, any of those contact.
Yes, sir.
Whether the child has received an immunization before the relapse.
Okay, sir.
Was it triggered by an infection? Infection was anyway there in the history.
Yes, sir.
Yeah. So you think of recurrent edema, most probably of renal etiology, most probably steroid dependent. Why do you say steroid dependent here?
Sir, I thought because there was the child was on treatment and they had stopped recently, so it could be a steroid dependent nephrotic syndrome.
What was the case? I thought it would be steroid dependent. There was a dependence episode this time. He was still on steroids when she relapsed?
Not on steroids, sir. They had stopped around 2-3 weeks back. So,
it may not be a case of steroid dependence.
It's not a case of steroid dependence, but could have had an single episode of dependence is what I see.
yes,
You should give it as frequent relapsing nephrotic syndrome here. You should not comment on dependent state here.
Okay.
This summary that you're giving.
Yes, sir.
Because for the first episode, looks like they're not treated it at all.
Yes, sir.
They just treated the edema and then gone home, and it's relapsed after a few months. Probably went into spontaneous remission for the first episode. We don't know because the child was well in between. So the second episode was what was actually treated as the first episode. 6 + 6 week treatment was given for the episode that happened in April or which month was it?
April ends.
April, yeah. So that would be considered the first episode, and this as the first episode of dependence. You cannot call it steroid dependence, but you can call it as the first relapse.
Okay, sir.
Okay. Now admitted for fever under evaluation. Okay, right. Okay, proceed.
So this is regarding this urinary tract infections. I would like to ask you a few things because PGs also might be taking part in this. So whenever a child has a urinary tract infection, which Dr. Nitin would be seeing regularly, so how do you proceed? Any brief idea that you can put forward? Child has UTI. So do you think you just treat the UTI and be done with it, or
No,
how do you go about it?
We have to analyze what would be the cause of urinary tract infection.
How do you establish a urinary tract infection?
Yeah.
First, we have to do a urine analysis. There, more than pus cells, more bacterial colony count more than 10 power 5 colonies. We consider it as
Colony forming units.
Colony forming units. We consider it as significant bacteriuria. Then pus cells more than 10 per hyperfilled in uncentrifuge sample and more than 5 per hyperfilled in centrifuge sample, we consider it as significant pyuria. And
with leukocyte esterase being positive.
Yes, ma'am. Screening the leukocyte esterase and nitrites positive.
Nitrates.
Positive.
Yeah.
So then you classify it into lower tract and upper tract.
Yes, ma'am. Then we have after the first episode of urinary tract infection, especially if the child is less than 1 year of age, we have to do some analysis like ultrasonogram, MCUG and DNSA.
No, you go stepwise. First, you will do an ultrasound because you can't order everything together, no?
Yes, ma'am. Yes,
yeah. So in ultrasound, what will you see? What are you looking for?
We have to look for if there is any structural abnormalities, like vesico-urethral reflux. Or if,
in ultrasound, can you make out just like vesico-urethral reflux? Mainly, you would like to see the hydronephrosis.
Hydronephrosis.
Yeah. First, you will see whether 2 kidneys are present. Then you will see where the 2 kidneys are located. Then what is the size of the kidney? Is there any scar on the kidney?
Scarring on the kidney.
Yes. Is there any active infection? They will mention it as perinephric stranding or some collection like that. And you will see for hydronephrosis or hydroureteronephrosis. You'll see whether the systems are dilated.
Yes, ma'am.
Okay, so these are the structural things that you will be able to visualize on ultrasound scan.
Yes,
so many a times it might be normal. Even though the child has infection, things might be normal.
Yes,
so then what do? You will treat the child for infection and then you will still have that suspect, right? That you have to find out.
Yes,
especially if the child has come with second episode, because here 1 episode in the past and 1 episode now, right?
Yes, ma'am.
Some 1 episode of previous UTI you have written.
It was during the first episode of Nephrotic Syndrome Clinical.
Yeah. So whenever there is
was that culture proven? Was there culture then?
Sir, I don't have the report.
History.
You don't know, right? In the history.
Yes,
yeah.
Yeah. So if it was, let us presume that if it was a recurrent UTI,
yes,
then you will also ask the history of voiding problems. Like, does the child strain to void? Okay. That will be an important history. Is the child straining to void? Or if the mother is able to feel a bladder, that is a ball-like thing in the abdomen. Pallavi, is it audible?
Yes, ma'am. Yes, ma'am.
Yeah, because your voice is very this one. I think you have to keep your volume a little high.
Okay. Is it audible now, ma'am?
Yeah, I know it's fine.
Okay.
So, is there any difficulty in voiding or straining while voiding? Or does the child complain of any pain while voiding? All this tell that there is some lower tract problem also.
Okay.
So also as you mentioned, since if the child has constipation problem, that will also add on to the infection rates here, because the child will have the bladder contractions which are not correct. It will be like a neurogenic bladder. So you'll have to find out if there is any feature of neurogenic bladder.
Okay.
It may be a little too much for an undergraduate level, but then whenever there is a history of recurrent UTI, the tract evaluation has to be important. For that, this history becomes very important.
Toilet training history is also important in this child.
Okay, sir.
Young child, right? 2
Yes,
years,
sir.
around 2 years of age. So you need to go into the history of toilet training, especially
Okay.
with the background of UTI.
Okay,
Whether
sir.
the child is in diapers,
Okay.
the urine stream, all those things. Yeah.
Yes, sir.
Usually, if the mothers, usually if they are noticing, then they'll be able to tell the stream of urine, the how the child passes, no, whether or is the child having any dribbling, they'll be able to mention that.
Okay.
Okay. So that stream of urine and straining while voiding, that history becomes important here.
Yes, ma'am.
Okay. So once this history is taken and you do an ultrasound scan, you'll see that everything is fine. And then the next important approach is to find out if there is any structural problem that is responsible for UTI.
Yes, ma'am.
And the most important thing will be the vesicoureteric reflux.
Reflux.
Yeah. So if vesicoureteric reflux.
What in a male child?
Yeah.
Pelvic PUG obstruction.
No, lower down.
Not the pelvic-ureteric junction, ma, the lower down, at the level of urethra. That's what sir is asking. Have you heard of PUV?
Yes, posterior urethral valve.
Yes. So posterior urethral valve, which is present congenitally, that can cause obstruction and bladder problems. So it is like a high pressure bladder. No, the bladder has to really strain to void, right?
Yes.
So that can also cause reflux. So either it will be a primary vesicoureteric reflux or a secondary reflux due to this neurogenic bladder or the PUV.
Yes, ma'am.
Okay, so in order to diagnose vesicoureteric reflux, our main aim in recurrent UTI will be this only. Because sometimes we may not be able to demonstrate vesicoureteric reflux or PUV. Therefore, after the ultrasound scan, maybe a month later, you will ask them to do a DMSA scan. Yes. So what does DMSA scan? How does DMSA scan help us?
We could see if there is any renal scarring present.
Yeah. How it is seen? What do they mention? They'll mention as photopenic areas. So if the scarred area is there, it will not take up the radioactive material. So that region becomes a scar.
Okay.
Right. So if there is a scar in the DMSA, then you are kind of warranted in doing an MCUG.
Okay.
So that is micturition cystoerythrogram. Yes, wherein a small catheter is inserted per urethra to the child and the contrast material is given. And then a film will be taken. Anyway, the details of which is a little bit too much for you all. But then we will be able to see how is the urethra, is there any significant, any stricture there, any obstruction there, how is the bladder. If the bladder is like high pressure, every time it has to really contract hard to push out the urine, then the bladder wall will be very thick, a corrugated kind of picture. And is there any reflux? Okay. Yeah. So I think this much, if you all know, for a UTI in a child should be okay. Dr. Nitin, you want to add something?
You need to
hear what you are telling.
Hello, it's audible?
Yeah, it's audible.
I couldn't hear what was telling. I got disconnected in between.
Yeah, now you are able to hear?
Yes.
Yeah.
Yeah, so you need to, could you define what is recurrent urinary tract infection? This child seems to have had more than one, so that's why.
Yes, sir. A colony count more than 10 power 5 units with the symptoms recurring for the second time is we can consider it as a recurrent urinary tract infection.
Okay, and what is persistent?
I'm not sure, sir.
So when there's a urinary tract infection, so there needs to be a first urinary tract infection, and after that you've treated it adequately with antibiotics, and there's resolution of symptoms, and There's a recurrent, a repeat episode of UTI after a period of 2 weeks, after being well for about 2 weeks.
Okay.
And if you have done a blood culture, urine culture, and it's the same organism, then it's a persistent urinary tract infection. If it's a different organism, or if it is more than 2 weeks duration between the two episodes, it's recurrent.
Okay.
Yeah.
Okay. So we'll ask her to proceed with this one, examination.
Examination.
General examination. Here is a 1 year, 11-month-old female child, alert, conscious, cooperative, oriented to the mother. Respiratory rate was 28 cycles per minute. BP 94/62 millimeter mercury. Temperature 98.6 degree Fahrenheit in the axilla. Saturation was 96% and capillary refilling time was less than 3 seconds.
This
What is oriented to mother? Oriented to mother.
Yes, sir.
Yeah. Why do you qualify that? Why don't you just say oriented? Oriented to everything, time, place, person.
Usually, like children, they wouldn't be able to tell.
She would be, no, at 1 year, 11 months.
And do you have the BP centile charts also with you?
I didn't mark it, ma'am, but it is less than SBP is less than 90% and diastolic was less than 95th percentile.
Yeah. So, Dr. Nitin, this blood pressure is okay for the child?
This is normal. This is normal for the child. Yeah.
More than 95th percentile would be
slightly on the higher side, around 90th percentile for this baby.
Yes.
Okay.
Yeah. Proceed to the next.
Yes, sir. Anthropometry, weight was observed as 10 kg, expected as 11.3 kilograms. Interpretation, it is between -1 standard deviation to median. It's normal. Height is 85 centimeters, expected is 86 centimeter. That's also between -1 to median. It's normal. Head circumference is 47 centimeter and it's as expected. It is normal. Mid-upper arm circumference is 13 centimeters. Expected is more than 13.5 centimeters. There could be a mild malnourishment.
Okay.
Head-to-toe examination. There is no pallor, icterus, cyanosis, flubbing, generalized lymphadenopathy, and edema. The head is normal. There is no facial puffiness. Eyes are normal. There is no cataract. Nose is normal. Ears are normal. Oral cavity is normal. No oral thrush. There is no tonsillar enlargement. Oropharynx is normal. Neck is normal. There is no lymphadenopathy. BCG scar is present. Chest is normal. Genitalia, there is no vulval edema. Spine is normal.
Male child, no?
Female.
Oh, female child. Okay.
Go back to that slide.
Yeah.
Yeah. So it would just be sufficient if you just mention that there is no dysmorphism. All right.
Okay.
In the face, and then your spine and genitalia. Yeah, you need to mention that in detail. BCG scar. It's okay. Yeah.
What do you specifically see in the spine, and why do you want to see the spine?
Any occult meningomyelocele or meningocele, it's there could be a neurogenic bladder, spina bifida, etc. So
you not mentioned the limbs, correct? In this examination,
there is no pedal edema.
Polydactyly,
syndactyly, defects, limb defects.
Club feet, anything like that? Nothing, no?
No, just normal.
Okay.
Systemic examination. Per abdomen, soft, non-tender. There is no palpable organomegaly. There is no free fluid. Respiratory system, bilateral air entry is equal. Normal vesicular breath sounds are heard. There are no added sounds. Cardiovascular system, first and second heart sounds were heard and there is no murmurs. CNS, there is no focal neurological defect. Overall, there are no abnormalities detected.
Okay.
How do you do a per abdomen examination? Inspection, palpation, percussion?
Yes, sir.
What do you see in inspection?
We have to check if there is any distended abdomen. There could be a fluid or any mass. Then if there are any scar signs in dilated veins, we have to just check it. Check. Then
Shape, distension, movement with respiration,
yes,
hernial orifices.
Hernial orifices, flanks. We have to.
Should have gone a little more detail in this case because this is a nephrotic syndrome case.
Yes, sir.
Yeah.
Yes, sir. But since there were no findings, I just thought I'll short.
Need to mention. Okay.
Okay, sir. And in palpation, we look for any organomegaly.
Yeah.
Then percussion, we have to look for any fluid like with the shifting dullness or fluid thrill, puddle sign, etc. Then we have to check for normal bowel sounds.
That's okay. Yeah.
Here, Pallavi would also like you to
Yes,
tell whether there are any signs of steroid toxicity. Okay.
Okay, ma'am.
Should have come in the head-to-toe examination.
Yeah, in the head-to-toe examination, that is
Cushingoid
very
features.
important. Yes.
Striae.
Yes, sir.
Yeah. Cataract you mentioned.
Yes, sir.
Yeah.
Yeah, but by the time the child is like this, no, they will, if at all the child has received steroids properly,
Yes.
if the mother was compliant, some
Yes,
amount of steroid features will be seen.
Okay.
So you need to mention them. If they are seen, they are seen. If they are not seen, they are not seen, but it's your duty to mention it.
Okay. Okay.
So what are the steroid toxicities from top to bottom? General?
Okay. Steroid toxicity features, there would be moon phases. Obesity would be there. There would be cataract, glaucoma, etc. eye signs. There would be
Buffalo hump.
Then osteopenia features would be there.
Proximal muscle weakness.
Yes,
You cannot tell
Still in the head, you should
osteopenia
mention
offhand.
acne. Acne is there? Yeah.
No, sir.
They will develop
Acne, hirsutism.
Hirsutism, then it's striae.
Frail skin, you know, their skin will become very frail so that the minimal scratch can become a wound.
Okay.
Okay.
Yes. Then history of any gastritis would be there.
Gastritis, bony pains, muscle weakness.
Yes, ma'am.
You have to ask whether they have any difficulty in getting up from squatting position.
Okay.
Okay.
Yes, ma'am.
So when these features are there, we kind of avoid steroids.
Okay.
And then the role of pediatric nephrologist comes, wherein we have to start on other medications.
Yes, ma'am.
Like tacrolimus or cyclosporin. Yeah, some steroid sparing agents. Yes.
Okay. Proceed. Continue.
Yes. Provisional diagnosis. This is probably a case of frequently relapsing nephrotic syndrome. It probably could be first episode of steroid-dependent nephrotic syndrome. Relapse due to upper respiratory tract infection and urinary tract infection.
Yeah.
Okay.
So when we have when the examiner has told you that it may not be steroid dependent, you will have to immediately kind of change over your diagnosis and do not cling on to the same diagnosis.
Okay.
Okay.
Yes,
that's the tactics that you'll have to use.
Yes, ma'am.
Because initially it was a steroid dependent is what you thought. Then we kept on telling you it may not be steroid dependent. So when you finally come to a provisional diagnosis and when you're pretty sure that the examiner is looking for something different, then stick on to frequently relapsing nephrotic syndrome because there is some analogy towards it. Okay.
Yes, ma'am.
Yeah. So
now
when
you have a
child
case
has
of
been treated.
First episode of nephrotic syndrome.
Yes.
So what are the things you need to look at before you start the child on medication?
Before we
How
start,
do you evaluate the child first and how do you start on treatment?
Sir, we have to do a urine analysis, then complete blood count, Then we have to do serum albumin level. Then
Okay.
we have to check for any complement levels. We have to serum complement levels.
Why complement level straight away? You should have gone to all the features of nephrotic syndrome: cholesterol levels,
Yes, sir.
serum
Yes,
albumin,
yes, sir.
renal
Serum
functions.
cholesterol levels,
Renal
then
function
creatinine, urea, creatinine. We have to check.
Would you want electrolytes?
Yes, yes, sir.
Yeah. So go methodically, no? Go from urine, then counts, then renal functions, electrolytes, cholesterol,
Yes,
liver
sir.
function tests. Would you want liver function tests also?
Yes, sir. Because there is a loss of proteins a lot and coagulation factors. So liver would be synthesizing more and more. So there could be elevated enzymes also.
What if your bilirubin is elevated, liver enzymes are high? Then what do you do?
There could be a history of jaundice, and that would have caused the relapse of nephrotic syndrome.
Okay. Which viruses can cause it?
Hepatitis B.
Yeah. Hep C also.
Yes, sir.
HIV.
Okay.
Yeah.
And then.
You mentioned complement, no?
Yes, sir.
Do you do complement routinely or?
No, sir, not in routine.
In which scenarios do you do it?
If there is recurrent, frequent relapses, and if there is any other features of significant lesions, we usually do.
Not frequent relapses, actually. Not frequent relapses. Frequent relapses wouldn't need it. But yeah, hypertension, hematuria, persistent microscopic or gross hematuria, then renal dysfunction, persistent renal dysfunction.
If there is any family history.
This is when you need to do complement. And ASO titers also.
Sir?
ASO titers. That also you would do, no? If there are atypical features. If the child is having gross hematuria, if the child is having hypertension at presentation.
Yes, sir.
And you would want to know whether it's a nephritis or a nephrotic.
Nephrotic.
Okay. So it's a typical nephrotic syndrome. Okay. First episode of typical nephrotic syndrome. Do you need anything else apart from what we mentioned before we start the child on medications? Indian scenario.
We have to look for, we have to do Mantoux test to rule out tuberculosis.
Chest X-ray and a Mantoux test.
Mantoux test. Yes.
Yeah. What if a Mantoux test is positive?
Mantoux test is positive. We have to start on anti-tubercular therapy.
How much of immunization is significant?
Sir, more than 10 mm is significant.
In an immunocompetent child. Yeah. So if there's immunodeficiency,
more than
5 is more than 5 is significant.
Yes, sir.
So if it is positive, then what do you do?
Sir, if it is positive for tuberculosis, then we have to start the child on anti-tubercular therapy. Then
the child doesn't have disease, right? It's just Mantoux positive, infected only. So prophylaxis is enough.
INH prophylaxis.
How do you give INH prophylaxis?
Not sure, sir.
What is the dose?
5 milligrams per kg is given per day.
Yeah, 5 to 10. We give 10 milligrams per kg per day for 6 months.
Okay.
And do you start steroid? This child is nephrotic. So do you start steroid or do you wait for starting steroids?
Sir,
If the mantle
immediately
is
we should
positive.
not start steroid. Immediately we should not start. After 2 to 3 weeks of starting INH prophylaxis, we can
2 weeks.
start with steroid.
Yeah, good.
Okay.
Okay. So how do you treat frequently relapsing nephrotic syndrome? What are the options you have?
Sir, frequently relapsing nephrotic syndrome, the second episode of relapse, we have to start first 2 mg per kg body weight of steroids till the urine proteins become normal. Then we have to continue with the alternate day of 1.5 milligrams per kg body weight for 4 weeks.
That's the relapse treatment,
be,
isn't it? That's the treatment for the relapse.
Yes,
but in a frequent relapser, 4 per year.
Frequent
then,
relapser.
What more do you need to do?
We can give it for about 9 to 18 months of steroids itself, or we can use steroid sparing agents like cyclosporin, cyclophosphamide, levamisole, myclophenolate mofetil.
So what is the steroid threshold? Any idea?
0.5 to 0.7. Less than, if it's less than 0.5 to 0.7, then I'm not sure, sir. No.
Steroid threshold is the lowest dose of steroid on which the child can be maintained without relapses.
Okay, sir.
All right. So if a child is having frequent relapses, then you can reduce the steroid very slowly and maintain a low dose steroid, alternate day steroid regimen for a very long duration. Like you mentioned, 9 months, 1 year. All right. That is one of the options. The other option is to add a steroid sparing agent.
Yes, sir.
Yeah. So what are the options you have for frequently relapsing?
So calcineurin inhibitors like
straight away?
No, sir. No, sir. Levamisole.
Yeah.
2 to 2.5 milligrams we have to give per kg. We can give this
daily or alternate days.
2 to 2.5 milligrams alternate days therapy for 12 weeks.
12 weeks? No, it's for 1.5 to 2 years.
Okay.
Along with steroids, low dose alternate day steroids for at least 9 months, 6 to 9 months.
Okay, sir.
Okay, and then steroid can be continued at a very minimal dose or completely stop.
Okay, sir.
Yeah. What else?
Cyclophosphamide, cyclosporin, mycophenolate mofetil.
How do you give cyclophosphamide?
We have to give it with the Mesna, sir, because there is features of hemorrhagic cystitis.
Most often you give it oral. Oral is preferred, isn't it?
Yes, sir. 2 to 2.5 milligrams per day. For 12 weeks we have to give. Then along with that we have to start Mesna also, because there is side effect like hemorrhagic cystitis, etc.
You don't give Mesna when you're giving oral steroid. You give it when you're giving IV.
Okay.
Sorry, IV cyclophosphamide, not for oral cyclophosphamide. All right.
Yes.
But what do you need to monitor? When do you give the tablet? What do you instruct the patient or the parent? And what do you monitor? What is the common side effect of cyclophosphamide? Early side effect? Or rather, more side effects are there. 2 or 3 of them are there.
Yes, sir. Not sure, sir. I'm not remembering now.
Yeah, cytopenias. Your WBC counts can come down. Yes. That is one. Hemorrhagic cystitis. That's the other. And infections. These are the early effects. If you're giving it IV, then there could be thrombophlebitis also. And late complications. What are the late effects of cyclophosphamide? Hair fall, secondary malignancies.
Secondary malignancies,
Yeah,
bladder malignancies.
Leukemia, all that. So when you're giving cyclophosphamide oral to a patient, you need to instruct the patient that he takes the medicine in the morning and maintains good hydration. Check the urine color, and they need to do their CBC at least once in 2 weeks.
Okay, sir.
Yeah, they say weekly, once a week, to see if the counts are in the normal range. So if the WBC count falls below 4,000, they generally withhold the cyclophosphamide for some time.
Okay.
Okay. Pooja, anything else?
Let us consider plain nephrotic syndrome. What diet advice will you give to the child?
The child has to consume high protein diet. About we have to consider about 2 to 2.5 grams per kg.
No, how do you tell? For every child, it is
You need to
2.5 grams.
mention. You need to mention in terms of RDA, percentage of RDA, protein intake, percentage of RDA.
But 1.5 times more we have to advise.
130%, 1.3.
Yes.
Yeah.
Then this salt intake should be restricted. There should be no additional salt to be added to the diet.
Okay.
Then.
So mainly for the protein, they usually tell in case this usually once we start steroids, the nephrotic range comes down, right?
Yes.
But if it is a frequently relapsing, always there is some amount of proteinuria.
Yes.
Then, as you said, the amount of protein intake has to increase.
Yes.
Do you give diuretic in nephrotic syndrome?
Yes, ma'am, but it should be given with caution. Initially, if there is a very massive edema, generalized edema, we have to give. Otherwise, it's not indicated.
Correct, because there can be intravascular volume depletion. Yes, so that's why initially it is avoided. But only if it is like a refractory edema, child having breathlessness, then only diuretic is recommended.
Usually, when the child, if it started on steroids, by 1 week, the edema will come down because of the steroids effect itself. In case it doesn't come down, then we have to advise for diuretics.
Yeah, correct. Because once the edema is resolving, they diurese more. And if we put them on diuretic, they'll continue to diurese more. That's why.
Yes.
Yeah.
Okay.
What are the complications of nephrotic syndrome? Can you enlist them?
Yes, sir. There could be relapse. Relapse could be there. Then edema would be.
Relapse
there.
is not a complication, ma. Don't.
Okay.
That's the. That's the disease per se, isn't it?
Okay. Okay, sir. Yes,
you talk about complications of nephrotic.
Yes, sir. There could be anemia.
Anemia. No.
Anemia, do not bring it.
And if there is anemia, it is atypical.
Yes, sir. Then thromboembolism would be there because of loss of coagulation factors in the urine.
You go with the most common. Infection is the most common complication.
Yes, sir.
Okay. Then hypovolemia.
Okay.
When there's a lot of third spacing and the intravascular volume is depleted, or if the child is on diuretics, or the child has concomitant sepsis, then the child can go into hypovolemia. You might have to give fluids. You might have to give albumin to the child. That's one of the indications for giving albumin in nephrotic syndrome, if the child has a lot of edema and intravascular volume contraction.
Yes, sir.
Okay. And then thrombosis. Yes, thrombosis is an important complication.
Yes, sir.
And AKI, acute kidney
failure could be.
What could be the
It's a-
causes of AKI in nephrotic syndrome?
Sir, because of hypovolemia.
Okay, one. Then? Pre-renal, you say.
Protein loss.
Whatever diuretic we are giving, that could be a cause.
Yes,
Or the
ma'am.
proteinuria itself can be a cause.
Yes, ma'am.
Okay, and if they have taken any NSAIDs along with that,
Any other drugs?
yeah, or infection itself can be a cause. Okay,
Okay.
very rarely renal vein thrombosis can be a cause.
Okay.
Okay, very rarely thromboembolic phenomena, no?
Yes, ma'am.
Yeah, but it is more common in membranous nephropathy.
Yes,
But
ma'am.
in children, it is less common.
Yes,
But
ma'am.
still, we need to keep that in mind.
Okay.
Okay, I think we have covered sufficiently. So Pallavi, Dr. Nitin, can we end the session here?
Yeah, we'll close the session.
Yeah.
Good presentation. Yeah.
A little difficult topic for the UGs.
Yeah. So what you need to look at is start methodically, in the sense that from the time the disease has begun, from the first symptom, you need to begin. So ideally, you should have started from February of this year.
Yes.
And gone into the detail of how they have managed each time it repeated. So the first episode in Feb, what they did, then what they did in April, what was the schedule of medication at that point, and were there any complications. So the focus has to be that way. And when you're taking the history, you need to look for the symptoms of nephrotic syndrome, then rule out the etiology of nephrotic syndrome in the history, and ask pointed questions regarding the complications of nephrotic syndrome also.
Yes.
Okay, so that's how you need to include in the history.
Okay.
All right, good. Thank you.
Thank you, sir.
Okay. Sir, can I conclude, sir?
Yeah, sure.
It was indeed a comprehensive clinical class. The discussion was very useful. Thank you, sir, Nitin sir and Pooja ma'am, for teaching us and guiding us. We are ever grateful to you, sir and ma'am. Need your blessings, guidance, and support throughout. It was a great effort by the presenter, Ms.Pallavi. We could learn a lot because of your well-prepared presentation. Also, thank you to all the participants who are actively involved. Thank you, one and all. Thank you, sir. Thank you, ma'am.
Thank you. Thank you, sir.